Sorry guys, I decided to change this right as I was turning on the recording. There. Alright. So I wanted to get you guys your exam review. I apologize it's a little bit late. I have been crazy spending 14 hours a day putting up my haunted house and trying to work and everything else. So I apologize. But this should really help understand which parts to study for. So remember our gestational age assessment, we want to do it just because we want to know if there's going to be any problems. We want to be able to predict any problems. Because if we determine that a baby is 32 weeks and another baby is 40 weeks, we're going to know that they're going to have totally different issues. So when do we do it? We do it immediately after birth, right? Right there while we're doing our APGARs, make a quick once-over, see if there's anything pressing, see if there's anything emergent, and then within 4 to 6 hours, and then at discharge. Know your cold stress. Infants have very small fat supplies, and their blood vessels are close to the surface, and they don't shiver like kids or big kids and adults. They shiver to warm up. Babies don't do that. So they burn their brown fat, which is on their back and on their clavicles. Just make sure to look at the slide and see where they are. So the less brown fat they have, the higher risk of cold stress they have. Know your different types of heat loss. Convection is cooler air currents, basically an air conditioner. If you think of an air conditioner blowing on a baby, the air is going to take away the heat. Radiation is heat loss because the heat is transferring to objects that are not in direct contact with the baby, maybe a cup of ice sitting on the table. Evaporation is the heat loss because baby's wet, whether it's a bath, whether it's right after birth and they're full of amniotic fluid. And conduction, that's heat loss because of objects that are in direct contact, whether it's a scale or a stethoscope, all those types of things. Cold stress is actually related to the age, the gestational age, and the size of the infant. Infants that are at a very high risk for cold stress are the premature, the small gestational age, and even the post-mature. So what are symptoms of cold stress? They're going to have more oxygen consumption, which means they're going to be breathing faster and shallower. They're going to be using up their calories, which they aren't taking in a whole lot right away. Their metabolism is going to speed up using that brown fat because the body's trying to make heat to keep them warm. They're going to produce fatty acid. They're going to produce unconjugated bilirubin, which means they are going to be at higher risk for jaundice, and their sugar stores are going to be decreased. Physically, they're going to have acrocyanosis, which their arms and legs are going to be blue because their blood is circulating to the most important areas, the trunk, to make sure that all the organs are staying healthy. The arms and the legs kind of get the second batch of blood, I guess. They're going to be sleepy, lethargic. You may see periods of apnea in between the tachypnea. They're not going to feed very well, and they're going to be in respiratory distress. We give babies their vitamin K shot right after birth because they don't have the normal flora in their gut to make the clotting factors. I can't remember exactly which ones are 2, 7, 9, and 8. I think, I don't know. Those clotting factors, they don't have them, so that's why we give them the vitamin K so that that can help make their blood clot. Know your normal assessment findings. Jaundice assessment. Oh. Make sure you're looking for jaundice in your babies. You can check by pressing on their forehead, their nose. So in order to decrease their risk of jaundice, we want to make sure that they stay warm. We want to make sure that they're pooping. Trying to get them to eat early during that first period of reactivity. We'll watch how much they're taking in. Obviously, it's difficult for a breastfed baby, but if they're formula-fed baby, we can watch the amount. And we're going to watch their billy levels. If they are getting high, the baby might have, phototherapy, or they might get billy lights or a billy blanket. Review the first period of reactivity, the period of inactivity to sleep phase, and then the second period of reactivity. That first period of reactivity, they're going to be really alert, really wide awake. So we want to make sure that we are making sure, we want to make sure that we are getting them to the breast if they are formula fed or a breastfed baby, because that way they can start getting food in their belly and making sure that they're not getting jaundice. Immediate signs, babies. No, think about what's priority when you have a new baby. Always airway, breathing, circulation. Baby's first stool is going to be a meconium. It's black, it's green, it's tarry. Generally, they pass it within 24 to 48 hours. Start to get a little nervous if they haven't pooped in 24, but just monitor them until 48. Breastfed babies are going to have yellow, mustardy, loose stools, whereas formula-fed babies are going to have like pasty, peanut butter colored kind of stools. Review the different parts of the Ballard score. Resting postures when they're laying flat in a crib. Square window test is when they bend their wrist over and their hand makes a square window. Arm recoil. Scarf sign where they're holding their arm over to the left, to one side. If the elbow crosses midline, they're preemie. Heel to ear sign, their skin, lanugo, the little surface of their little feet, their breast bud tissue, their eyes and their ears, and their genitalia. Remember that active immunity is the infant will actually form their own antibodies because of getting sick or getting an immunization. Passive immunity is the immunity that's transferred from mom to baby. Colostrum has a lot of immunity in it, the IgA. But this doesn't make baby invincible. Acrocyanosis, we talked about, that's the blue, cold hands and feet caused by poor perfusion. I will tell you that I have seen babies just born. They had acrocyanosis so bad on their foot. I literally walked in and saw my student, and I thought she had just taken the baby footprints because I saw the bottom of the baby's foot, and it was that dark blue. All they did was they didn't want to worry mom, so they brought baby in and said, "Oh, he needs some skin-to-skin time," and snuggle up with him. And sure enough, that worked. His feet were pink within an hour. So it's just poor perfusion, helping their little bodies learn how to perfuse. Physiological jaundice. No non-pathological unconjugated hyperbilirubinemia is just the inability to conjugate the bilirubin. Know that the causes of this is, Their red blood cells are shorter, have a shorter lifespan than adults. They might have bruising during delivery. If they are face first, they may come out with lots of bruises on their face, even if they end up being C-section. The trauma to that baby's face. Maybe they're not eating right away during that first period of reactivity, or their stomach isn't, or their bowels aren't moving as fast. Like I said, maybe a traumatic birth. Cold stress will cause jaundice, respiratory distress. If they're dehydrated, they will show signs of jaundice. And if they're septic, they'll show signs. So remember that we need to keep our babies warm, make sure they're pooping, and get them eating so that they do poop so they can get that bilirubin excreted. The risk factors kind of go along with some of the causes, obviously. But if they're not getting enough food from breastfeeding, insufficient breastfeeding, if they have a family history of jaundice, bruising is a big, huge one. Anytime they've had an assisted delivery with a forceps or a vacuum, cephalehematomas, Asian ethnicity has a higher risk of jaundice. Anytime the mom's greater than 25 years old, and male gender of the baby, and the gestational age. Remember, preemies have a higher risk of jaundice. Know your reflexes. The moro is the abduction and adduction of their arms and crying, so you bump into their crib and they jump and arms flail out. Grasping, they can hold on to things when they put them in their hand, like if you stick your finger in their hand. Babinski, where you touch their foot and their toes fan out. Rootings, when the baby turns their face towards whatever. If you rub their cheek, they will look for a source of food. And sucking, anytime you touch the roof of their mouth, they start sucking. Postpartum diaphoresis, review that. Mainly it happens at night. If they are running a temperature or having any other signs of infection, it can be a cause of infection, but it also may be a normal finding if there's no fever, no infection anywhere. All we do basically is support mom, give supportive measures, treat the symptoms, help her change her gown, get her clean bedding, and just let her know that this can be a normal thing. Or, if you take their temperature and her temperature's fine, say, yep, this is a normal thing. Moms do this, just trying to get rid of all that fluid, because when you're pregnant, you get 50% more blood volume and the body has to get rid of it somehow. Lactation. If you have a mom who is bottle feeding and they're not going to breastfeed at all, we need to teach them to put ice packs under their armpits for 20 minutes 4 times a day. Not to put any heat or have any stimulation for at least a week. And wear a tight-fitting bra. I always say if you wear one size smaller, it'll really squish the boobs, so that'll help suppress lactation. Location of the fundus after birth. This kind of sentence is kind of wonky. During pregnancy, that fundus will raise depending on which week you're in. After birth and that baby's expelled, it'll be way down in the pubis, behind the pubis. But immediately after that placenta is expelled, that fundus rises back up to the umbilicus, not 6 to 12 hours at the umbilicus, but so I don't want you guys to, I'm going to get rid of this right now. But make sure you're looking at the resources I put out there about where the fundus is and what day and right after. So taking in, taking hold phase, make sure you know those. Taking in is mom's pretty passive and dependent. It's right after she's delivered. She's focused on herself. She's hungry. She's tired. And she's just kind of taking everything in. Once she gets some food and some sleep, she will start the taking hold phase where her number one concern is the baby and how to care for the baby. She's going to be more confident. Postpartum vital signs, temperature might be elevated right after birth. Blood pressure might raise immediately after birth, but this is, because she's having contractions. And that pulse might actually drop down to like 50s to 70s and be kind of Brady. Just because, like I said before, moms have so much extra blood, and with the delivery and all that, they start to get rid of some of that. So they have a decreased blood volume that their body's not quite used to. Respirations are generally baseline. They don't get affected. Maternal role attainment. Remember, these are the steps. Know your steps. Mom is just learning her mothering behaviors and trying to identify herself as a mom. She begins out by listening to everything everybody says, and then by a year or so, 10 months to a year, she's got her own thing going and she's doing well. So we need to look for this during the beginning and the hospitalization. Maternal danger signs. Especially after mom has gone home, we need to make sure that this is what we tell them. Call your doctor anytime you have any of these. If they're running a temperature over 100, if they have any hard, red, painful, or warm areas in their breasts or in their low extremities. It could be mastitis, it could be a blood clot. We need to know if they have any foul-smelling vaginal discharge. And if their lochia becomes heavy and they're saturating more than they were, yesterday. If they've got sadness that goes past the baby blues. If it lasts for 7 to 10 days and it's extreme and they're having trouble taking care of the baby. And then if they just don't feel right. You guys will learn that moms and even other patients too, but they get a gut feeling that something's wrong, and generally there is. Know how to care for a C-section mommy after delivery. Know your nutrition facts. The non-breastfeeding mom will return to their pre-pregnancy requirements. So during pregnancy, they ate an extra 300 calories a day. When they're not breastfeeding, they're going to go back down to whatever they were, and they're going to decrease their calories by 300. So they'll be back at their pre-pregnancy requirements. The breastfeeding mom is actually going to increase their calories per day by 200 above their pregnancy amount, because they need more to keep their milk from milk producing. So they have their 300 calories a day extra from pregnancy, and then this extra 200. So it's going to be 500 calories above pre-pregnancy with increased protein and calcium. Know your lochia. The lochia rubra, the lochia serosa, and the lochia alba. After pains, these will happen with contractions for 3 days after delivery. When mom is breastfeeding, they occur because mom excretes oxytocin. If there's distended, What do we do for sorry, Boston was just calling me. I'll have to call them back in a minute. Treatment, warmth on the belly. We're going to give them Tylenol or something mild before they start breastfeeding. And we're going to have them lay on their belly. when a uterus is boggy, can't talk. Boggy, we are going to massage their uterus. We're going to have mom urinate. We're going to reassess it again. We're going to massage it again, just so that we can try and get that uterus to firm up, so that they can quit bleeding. Uterine atony. The contractions of the uterus are either not occurring or they're not strong enough to cut off any of that bleeding. Blood loss doesn't have to be all at once. It can be slow and steady. So this is why we need to make sure that we are completing all of our assessments. The fundal assessments, the lochia, they're vital signs. But remember, vital signs is the late sign, so we want to make sure to do the fundal assessments and the lochia. Risk factors, if the baby's big or a lot of fluid or, there's a couple of babies in there or 3 babies. If their labor is prolonged, if they were induced into labor, they've had lots of babies. Anesthesia can also increase it. If they spend more than 30 minutes in the 3rd stage, if they had preeclampsia, Asian or Hispanic ethnicity, C-section, forceps, or vacuum births. If that placenta is still in there, the uterus will not contract, so we need to make sure that's out. Placenta previa or placenta accreta, and obesity. So our treatment, we're going to give oxytocin, which we do after delivery, and we're going to hold traction on that umbilical cord. But remember, we're not going to pull it. We're just going to hold it. And then we're going to use uterine massage, but we do not do massage until that placenta is expelled. So if our mom has heavy lochia rubra, or heavy bleeding, so our goal, we want to get that uterus to contract to cut off those blood vessels. We're going to massage. You can take her down. Sorry guys, Bailey's trying to be really quiet with that stupid dog we have, and she's going to come down for a minute, so then she'll go back upstairs. We're going to massage that fundus to make that uterus contract. We're going to have mom void, so that it's not pressing on the uterus, causing it not to to stay boggy. We're going to give meds so that the contractions, to help the uterus contract. And we're going to assess the amount that she's bleeding. If we go in, we have mom go to the bathroom, change her pad, and then in an hour recheck it to see how much she's bleeding. Postpartum chill. It's common. Extreme shivers after birth. I've always thought it was kind of the adrenaline, but it might be release of pressure on the nerves, epinephrine, transfusion during the separation, the change of body fluids, and the metabolic effort. If this is accompanied by a fever or any other signs and symptoms, then it may be a sign of infection, but without those signs, it's just a normal thing. Chlamydia, males have the non-gonorrheal gonococcal urethritis with an increased risk of transmitting HIV. Females, pelvic inflammatory disease, infertility, ectopic pregnancy, and an increased risk of transmitting HIV. A lot of times chlamydia and gonorrhea are diagnosed at the same time, especially if they're treating the male for NGU. So symptoms are going to be this thin, purulent discharge from the vagina or the penis, burning or frequency of urination. That cervix is going to be inflamed. They're going to have pain in their lower abdomen, but they also may be asymptomatic. Diaphragm, this is just that physical barrier that fits over the cervix. The provider has to place it, used with a spermicide, which is the chemical barrier, and the spermicide needs to be applied every 6 hours, and the diaphragm needs to be left in place for 6 hours after intercourse. The Hunter or the postcoital test, that's just used to check the basically how well his sperm swim. Herpes type 1 is the cold sores, type 2 is the genitals. Going a little fast here. Primary outbreak can happen right away or within 20 days. There's blisters on the genital areas, which can open. And then the lesions will heal within about 4 weeks, but the virus still stays in the body. So these people might have exacerbations if they get stressed out, sometimes with menstruation. If they're ovulating, pregnancy will bring out an exacerbation. Vigorous intercourse, poor health status overall, if their clothing is too tight or they're overheating. Treatment is the antiviral, acyclovir, and sometimes they will take that only at outbreaks or every day. It just kind of depends on what their provider wants. Dysmenorrhea, remember this is the painful menstruation, the painful cramping. Starts the day before and goes till the end. Primary dysmenorrhea, there's no other, that's the issue. There's no other disease that's causing the cramps. And this is probably caused by the uterus is more contractile. Uterus contracts harder than normal, and decreases that arterial blood flow, so that uterus is actually experiencing ischemia and tissue death. So treatment is just NSAIDs, warmth, contraceptives. Secondary dysmenorrhea is caused by a illness, a disease. Could be endometriosis, PID, cervical stenosis, fibroids, ovarian cysts, tumors, IUD placement. So just to treat that secondary dysmenorrhea, we just move the problem. Amenorrhea. Menses is not started by age 16 or within 4 years of breast development. This is a classic sign of anorexia, especially in our teenagers that get bullied so much about their weight. Secondary amenorrhea is the cessation of the menses. It started, but it is now stopped. Could be caused by pregnancy, breastfeeding, problems with hormones. If their nutrition is poor, or like for an anorexia, or in the case of anorexia, if they've got strenuous exercise, like a gymnast, if they're stressed out, or a low fat to lean ratio, which is also the exercise. Treatment, we're just going to treat the cause. If they're exercising too much, we're going to back them off. If they're poor nutrition, we're going to find supplements and get them better and see if it comes back. PMS, sorry guys, correlated with about 2 weeks before the menses starts. Symptoms, irritability, depression, problems sleeping, crying spells, nausea, vomiting, constipation, bloating, craving for sweets, and breast tenderness. For treatment, we're going to want to have them decrease the amount of alcohol, the amount of nicotine, red meat, sugar, salt, and caffeine. Make sure that they're intaking low amounts of all of that. Just different vitamins and minerals to help with different aspects of it. You can look those up. Perimenopause, remember this is the time when menopause is actually fluctuating, or function of the reproductive thing, not menopause, sorry, I was looking at the page, bottom of the page. It's actually fluctuating, and so they're getting their period, but it's irregular. But they can still get pregnant. So they're going to have PMS symptoms. They're going to have hot flashes, irregular periods, trouble sleeping, decreased libido, vaginal dryness, mood changes. And then once that menses has been gone for a year, it is now termed menopause. Generally, this is between late 40s to 50s. Symptoms are going to be hot flashes, night sweats, sleeping too much, sleeping too little, dizzy spells, palpitations, weaknesses. Know your signs of ovulation, the cervical mucus assessment, the amount, the wetness, slipperiness, color if it's clear, the spin bark heat. Venereal warts caused by the HPV. Some strains of it may actually cause the cervical cancer. The symptoms of venereal warts are going to be these lesions that actually look like a cauliflower, a big wart on the genital area, itching or burning. It's going to be painful for them to have intercourse. The only treatment for that is the prevention, which is the Gardasil and the Cervarix vaccines. Infertility, just know that if someone's been trying to have a baby for 12 months, that's when they may deem them infertile if they're not able to get pregnant within 12 months. Gonorrhea, the female is going to have purulent green, yellow, foul-smelling discharge. They're going to have trouble urinating frequency. Their vulva is going to be inflamed. Their cervix is going to be swollen. But then they also might be asymptomatic. Male symptoms, they're going to have urethritis, which is the telltale sign. Burning with urination. They're also going to have the yellow-green yucky drainage from their penis. Treatment, they're going to be treating both partners, antibiotics. Long-term complications, they're going to have more infections, heart disease, arthritis, blindness. Then they may become sterile. Review the basal body temperature. And know fertility. What helps these moms become more fertile? Remember we talked about douching, and they actually kind of affect how well the sperm can swim. Teach them to try and keep the sperm from leaking. Encourage intercourse every other day, not every day. The more they concentrate on it, the less likely the pregnancy is going to happen. Oh, yeah, that's the next one. I will say that I have seen lots of people try, and when the minute they said, fine, we can't have kids, within the next month they were pregnant. Make sure that they've got adequate nutrition, and make sure that they're not stressed out. So this is the review in a nutshell. I did it kind of quick. But if you guys have any questions, like I said, this weekend, text me. Don't email me because I won't see it. So just text me. But if you need to talk to me, text me and say, hey, can you call me? And I will take a break and give you a call. So I just want to be available if you guys have any questions for the exam. I don't want to leave you out there just because I've got craziness going this weekend. But yeah, text me and let me know if you guys have any questions. And good luck.